So, Assalamu alaikum everyone. Good afternoon. I am Dr. Kashif Shazlee, Chairman Imaging Services Indus Hospital Networks, and the topic is very interesting. It is mitigating the COVID exposure risk, and we all know that this infection, viral infection, never came in the history of human being, and it is the first time that the lockdown worldwide is so much that everyone is being influenced by this corona and COVID pneumonia, and everywhere there is a fear, and even the healthcare professionals are at risk. So, first of all, here is my disclaimer. This is fair use, and all the material which is being used here for teaching is actually basically from the internet sources and some from my own sources. So first of all, this is very important slide, and I think we need to understand. जब मैं सुबह निकलता हूँ अपने घर से, तो सबसे पहले जब गेट से बाहर जा रहा होता हूँ तो हमारा वेस्ट ओपन हाउस है, तो मुझे सूरज निकलता हुआ नज़र आ रहा होता है, और रोड से ये छोटा सा जो एक पौधा है ये निकलता हुआ नज़र आ रहा होता है, और रास्ते में जाते हुए रोडों पर कहीं इस तरह हंसते मुस्कुराते बच्चे भी नज़र आते हैं, और बहता हुआ पानी, समंदर, ईच एंड एवरीथिंग, हर चीज़ हमें एक होप दिला रही है कि जो भी प्रॉब्लम आई है इंशाल्लाह बहुत जल्दी हम इससे निकल आएंगे, और तमाम का तमाम बिलीव अल्लाह के ऊपर है कि इंशाल्लाह हम इस मुसीबत का सामना जो कर रहे हैं ये हमारी एक आजमाइश है और हम इससे निकल आएंगे। तो ये होप हमें बरकरार रखनी है, और जो असल इशू है वो मिटिगेटिंग द एक्सपोजर रिस्क से ज़्यादा ये है मिटिगेटिंग द कोरोना एंजाइटी। वंस मेरी क्यूरी टोल्ड that there is nothing to fear in life, you just to understand everything. Actually, corona is a virus, and it's a flu-like virus. It's till now its death toll in our country is just 1.8% of the infected population. So more than its death toll, the anxiety factor is taking lead, and everyone is anxious about that there is corona. Even people are happy to hear that they have tuberculosis of the lung, but they don't have coronavirus. So this level of anxiety actually is not required right now. We have to face, it is inevitable now in our country, even in the whole world, it is inevitable now. So we have to prepare ourselves, we have to face this phenomenon, and this phenomenon is actually a warning sign for human being and human generations to correct their maldoings and to correct their practices. As we all know that in last decade, 10 crore and 80 lakhs human beings were killed by wars of different countries. 10 crore and 80 lakhs. 10 crore and 80 lakhs were killed by wars, and human being made lot of वॉर मटीरियल, असलहा, हज़ारों तरह का हम सबको पता है कि असलहा है, एंड लॉट ऑफ मनी इज बीइंग स्पेंड on wars. So the corrective measures should be taken now for future, for our generations, and we should rethink, reschedule, replan our things, and to overcome the corona anxiety, we have to think positively, we have to see the future positively, we have to change ourselves. So the change is coming from inside, it should be coming inside, from inside, and we have to see the future. So the basic concept of mitigating the corona risk is based on self-protection, the social distancing, or I must call it physical distancing, and the provision of protective gears or personal protective equipment to the healthcare professionals. These three are the important ones: the self-protection, the social distancing or physical distancing, and the third one is provision of PPE, personal protective equipment. So the basic concept is very simple. We don't have any cure, we don't have any vaccine or any drug which can beat the coronavirus. So the simple and basic rule is to protect yourself, your colleagues, your family from this virus. This is very basic. And the most importantly, as the health facilities worldwide are proven to be insufficient, especially in our country, these are very insufficient. So we have to be very careful about our healthcare professionals. We have to have personal protective equipment and protective gears for the sake of safe of our healthcare professionals. So who are the patient at risk for COVID-19? These are person in areas with ongoing local transmission, healthcare workers caring for patient with COVID-19, close contacts of infected persons, and travelers returning from local locations where local spread has been reported. So these are all are at risk, uh, I will say everyone is at risk right now because it is a pandemic, and now it is coming everywhere in Pakistan as well. So who is at high risk of complication? The most common complication are occurred in older patients and the patients who have already serious underlying health conditions like heart diseases, diabetes mellitus, pre-existing lung diseases. For such individuals, they should consider some precautions. They should avoid close contact with the sick people. Even if a person is sick, he should be careful. He should maintain a distance from other sick patient, not only the corona patient, but from other sick patient. They should wash their hand very frequently, or they should use sanitizer. They should stay at home as much as possible, especially the areas where corona is outside their door. So they should be very careful, especially the older patients. uh, I would give some advice for the patients, and we, as a physician, we must provide some education. We must train our population, because this is not a story of 1 or 2 weeks. It will go around 2 or 3 months more from now. So we have to educate our people. Lockdown is the final solution. This is not the first solution. So to ease the lockdown, we have to educate our people, and especially it is responsibility of physicians and healthcare professionals to educate our people and patients. So the general advices for patients are: patients who do not require emergency care may better contact their doctor over the phone or online healthcare services. There are so many healthcare services available nowadays. Big hospitals are offering, and some organization like Pakistan Islamic Medical Association has announced a very big online healthcare service. So patient can get opinions from experts online. They should spend minimum time outside their home, including the clinic time or the time when the physician is giving the opinion. The whole time must be minimized. Adult patients should be encouraged to come alone at clinic, no children or no mop with them. And if the patient is children only or a disabled person, only one attendant should be accompanied. So these general advices should be given to our patients. Similarly, there are few very important suggestions and precautions for our general practitioners, like they should consider their health at first. Doctors older than 60 having different comorbids should close their practices. It is very important. And we all know that our beloved GPs, including Dr. Somro, who martyred last week, he was doing his general practice in Badin and he got infected. So it is very important to protect ourselves. And the general physician uh, can give his or her opinion by telephone, or we should use telemedicine options. There are so much telephone, so much social media options, telemedicine options that general practitioner can maintain their usual practice with the help of these gadgets. So if, unfortunately, if a physician is attending a COVID-19 suspected patient, a patient comes to OPD with the clear-cut symptoms of COVID-19. So what he or she should do? So she should do, or he should start his attending the patient with the name of Allah. He or she should take all necessary precautions. And actually, the COVID patient are not recommended to handle in OPDs or clinics, because such patients require designated areas. They should be sent to a dedicated health facility, and government kindly has mentioned so many facilities, especially in big cities of the throughout the countries, that these patients should go there. But if unfortunately someone comes across with such patient, they should take some precautions, like the patient should be dealt within a separate room with minimum possible time. They should wear surgical masks at least. The health person should wear gloves as well. If available, N95 mask and eye protection should also be taken. Other standard contacts and airborne precautions should be observed by the patient, like hand washing, covering of the face with tissue, rumal, any other thing available, especially when the patient is coughing. The doctor and other clinical staff should contact the nearest COVID-19 referral center for their screening. And as usual, if the patient is not a COVID suspected patient, then what should be the protocol? What precautions we must take as a general practitioner? So there are some responsibilities which should be designated to the clinical assistant, और जो हमारे छोटे वहाँ पे होते हैं clinics पे helper होते हैं या compounders होते हैं, तो they should avoid the crowding at the clinic. The number of patients should be limited at a time. यानी आप ये कर सकते हैं कि आप 5 से 10 पेशेंट एक घंटे के अंदर देखना चाह रहे हैं, तो आप सोशल डिस्टेंसिंग के साथ उनको बिठा लीजिए. कंसीडर फिजिकल डिस्टेंसिंग बिटवीन द पेशेंट. इट इज़ वेरी इंपॉर्टेंट पॉइंट. हमें नहीं पता कि कौन सा पेशेंट आ रहा है और कौन सा पेशेंट जो है वो कोविड का पॉजिटिव हो सकता है. दो के उसके सिम्टम्स नहीं है, लेकिन कोई भी पेशेंट कोविड पॉजिटिव हो सकता है. सो वी मस्ट कंसीडर एवरी पेशेंट suspected to have COVID. If possible, filtered suspected patient at a point of entry by an assistant. वहाँ पे आप प्रोफॉर्मा रख सकते हैं या कोई ऐसा बंदा खड़ा कर सकते हैं जो कुछ बेसिक क्वेश्चंस पूछ ले उससे कि आपको बुखार तो नहीं है, आपकी कोई ट्रैवलिंग हिस्ट्री तो नहीं है, आपकी किसी जानने वाले में कोरोना डायग्नोज तो नहीं हुआ, आपको नज़ला जुकाम खांसी या बुखार तो नहीं है. ये बेसिक क्वेश्चंस हैं. दीज आर द बेसिक क्वेश्चंस एंड मस्ट बी आस्क्ड बाय सम असिस्टेंट आउटसाइड द क्लिनिक, के वो फिल्टर करके ही अंदर भेजे. Everybody in clinic should wear a surgical mask, including patients. Place a prominent notice at front. अपने clinics के बाहर या अपनी OPDs के बाहर हमें लगाने की ज़रूरत है. Hand hygiene is of prompt importance, और hand sanitizer ज़रूर होने चाहिए. Washing के लिए बेसन होना चाहिए, facility होनी चाहिए. Hand sanitizer must contain 70 to 75% ethyl alcohol और propyl alcohol. अगर उसमें 70 to 75% अल्कोहल नहीं है, इट इज़ यूजलेस. सो बी केयरफुल. द अवेलेबल जो मार्केट में मिल रहे हैं सैनिटाइजर, बी केयरफुल एंड प्लीज रीड बिफोर यूज. यूज ऑफ डिस्पोजेबल शीट्स इज रिकमेंडेड whenever patient is being examined. All surfaces should be frequently disinfected with 20% bleach solution or alcohol solution, or whatever the solution available. Especially the bleach is the most effective solution for cleaning. At the end of the clinic or OPD, the floor must also be mopped with bleach solution. Precaution. As a doctor, we must sure about our personal hygiene. We must wash our hand after every patient. We must maintain a distance of at least 3 feet with the patient. We must wear personal protective equipment whenever and wherever required. स्क्रब आर रिकमेंडेड कि हम वहाँ जाएं और तो क्लिनिक में या हॉस्पिटल में तो स्क्रब्स पहन लें और वापसी पे उनको उतार कर आएँ ताकि इन्फेक्शन हमारे घरों में ना आए. Avoid close contact if auscultation is necessary, auscultate the patient from back side, not from front side. जो भी हमारे पास इक्विपमेंट होते हैं, फॉर एग्जांपल डायफ्राम, स्टेथोस्कोप वगैरह, वी मस्ट क्लीन दीज इक्विपमेंट्स आफ्टर एग्जामिनेशन विद अल्कोहल, एटलीस्ट 70 to 75% अल्कोहल. ENT and eye examination, we must use फेस शील्ड. यहाँ पे लाजमी आपको फेस शील्ड यूज करनी पड़ेगी, अदरवाइज मैं बताते चलूँ, द फर्स्ट डॉक्टर हु डाइड मार्टाइड इन UK, he was Pakistani ENT surgeon and he was just draining a tonsillar abscess and he got infected while he was doing surgery. So it is very important to wear a surgical mask and face shield while examining the eye or ENT. Avoid using nebulizer or aerosol generating procedures. We must avoid in OPDs and in clinics. And after finishing our OPD, we must again wash our hand with soap or sanitizer. Clean all the surfaces including floors, furnitures with 20% bleach solution or whatever available, whether alcohol or bleach. Separating washable linen and clothes is very important. These should be disposable. If we can't afford the disposable one, then daily washing is highly recommended. आपको रोजाना धुलवाना पड़ेगा, otherwise इससे भी infection transmit हो सकता है. So कौन सा डॉक्टर क्या पहनेगा? Important is if you are doing just OPD of non-COVID patients, you must use hand sanitizers, you must wear surgical mask, and you must wear gloves. If you are doing your duty in emergency, you should take precautions with sanitizers. You must wear surgical mask, gloves, face shield, and gown. Here is the disposable gown you can see on your left hand side. Similarly, if someone is doing duties in COVID isolation ward, he or she, this doctor must take all these precautions except goggles, and whenever required, goggles are also recommended. If the doctor is performing his or her duty in COVID ICU, the maximum protective gear are recommended in COVID ICU. And the doctor who is involved in aerosol generating procedures, he should also take maximum protective gears. At least 70 to 75% alcohol is must in sanitizer, please remember. In hospital settings, we must reduce our working hours. We must make our rosters on with minimum staff and maximum outcome basis. We can do alternate duties or duties with gaps. Like अगर कोई कर रहा है 7 दिन कंटिन्यूस हॉस्पिटल में ड्यूटी कर रहा है तो 14 दिन फिर उसको ऑफ मिलना चाहिए क्वारंटाइन के लिए. Only emergency situations should be dealt in hospitals right now, and routine patients must be rescheduled. उनके साथ जो अटेंडेंट आ रहे हैं वो भी लिमिटेड होनी चाहिए, रिस्ट्रिक्टेड विजिटर्स एंट्री होनी चाहिए और एंट्री के ऊपर 100% compliance हो with screening, 100% compliance. And hospitals should use telemedicine facilities for their patients who are not emergency. For doctors and healthcare professionals, again, provision of personal protective equipment is very important, and it is the responsibility of government. It is the responsibility of the private institute to provide personal protective equipment whenever required, wherever required, and it is unacceptable to call a doctor without PPE. It is very important to take precautions, and worldwide it is a big issue to provide PPE, but in Pakistan, alhamdulillah, now people, there are people who are providing in personal capacity or as an organization capacity, and government is also striving to provide these PPE, but No services without PPE. Please remember, no services without PPE. So these are some important images showing what to wear and when to wear. And you can see here for patients and for the staff who is dealing with non-COVID patient within a hospital setting, he or she must wear a disposable gown, a surgical mask, and gloves. The staff at reception or who is doing general duties like the uh, the office staff, the human resource, etc., they must at least wear a surgical mask. They should use gloves, or if gloves are not available, repeated use of sanitizer. The doctors or healthcare professionals within COVID designated area or as aerosol generating procedure area, they must wear full PPE, including full suit, the head or face shield, the goggle, and N95 mask. These are very important, very important. Here is some detail about this is the last slide, probably second last slide. Disinfectant solution are very important, and the most effective solution is bleach. And the simple method to prepare bleach is the whatever available in market, take the solution, just put 5 teaspoons of bleach into 5 liter water, and you can mop with this solution, and this is very effective. If alcohol solution is available, it must contain 70 to 75% ethyl alcohol or isopropyl alcohol. It is also very effective. And if within alcohol we can add 3% hydrogen peroxide, it is even more lethal for all type of germs, viruses, etc. Simple cloths should be washed with simple detergent or surf, whichever is available, and these are very effective. If required, we can offer fumigation of our corridors, especially radiology department or where the patient stay is more than 10 to 15 minutes, we can fumigate. Please remember, fumigation is not recommended in radiology rooms, which in radiology rooms with heavy equipments like CT scan or MRI, because it can cause the malfunctioning of these. So while reaching home, general precautions should be adopted, such as removing shoes outside the main door, putting clinical cloths in separate container for washing, and the person, doctor, he or she, him or herself should wash these clothes. आप जब वॉशरूम जाएंगे तो खुद ही आपने ये धोना है पहले और उसके बाद नहाना है. ये नहीं होगा कि आपने बेगम को या हस्बैंड को या कोई किसी को भी हैंड ओवर कर दिए और उससे कहा जी आप जाके धो लें. उसको नहीं पता होगा, लिहाजा ये क्लॉथ्स आपको खुद वॉश करने हैं. प्लीज प्लीज प्लीज. और इसके धोने के बाद ही आपने वॉश करना है प्लीज. इसके अलावा जो बहुत ही इंपॉर्टेंट है रिकमेंडेशन, वो 50 टू 60 डिग्री सेंटीग्रेड का जो गर्म पानी है उससे अगर आप धो सकते हो तो बहुत अच्छा है. नो नीड ऑफ पीपी टू ब्रिंग एट होम. वहीं पे हमें छोड़ना है, पीपी घर लेके नहीं आने हैं. इवन मास्क के अंदर N95 मास्क यू कैन यूज 5 to 10 टाइम्स रिपीटेडली इफ दे आर पैक्ड इन अ पॉलिथीन बैग. अगर ये उसमें बैग में है तो आप इसको घर पे लाने की जरूरत नहीं है, इसको ऑफिस में छोड़ के आइए. It is suspected that with the use of these recommendation and sensible approach, the practitioner, general physicians and doctors will protect himself or herself as well as carry on his or her usual duties. May Allah Ta'ala help us all. Thank you very much. Over to Dr. Azim.
Thank you very much, Dr. Kashif, for your nice talk, very comprehensive one. So we will move on. We have received a number of questions, but we will take the question at the end of the session. And we'll move to the second speaker. And for the interest of time, I would request all the remaining speakers to finish their presentation within the allocated time. So the second speaker is Dr. Kiran Hilal, and she is going to talk on rapid advice guidelines about the role of imaging in COVID. Over to you, Dr. Kiran.
Assalamu alaikum. I hope everyone can hear me. Can you hear me?
जी जी
आ
आप
रही है
clear.
आवाज?
Okay. Assalamu alaikum. Bismillahirrahmanirrahim. Thank you for the kind introduction, Dr. Azim. Thank you, especially the Gets Pharma, for making me the part of this webinar. Today, I'll be talking about the role of imaging in COVID-19, a bone of contention these days. Lots of discussions are going about this topic. To start with, I have no current or past relationship with the commercial entity which organized this meeting, and I have no financial disclosure with the materials of this presentation. So what I'm going to talk about in this talk is I'm going to answer these 7 questions in this talk, which are these are the topic of discussion these days considering this pandemic. Where the Pakistan is standing in this pandemic, why we need protocol for this pandemic, what are the limitations of our currently available gold standard, which is PCR, what are the NIH, which is the National Institute of Health Services Pakistan recommendation, and the challenges that we are facing in Pakistan, what are the current recommendation by Radiology Society of Pakistan, what international data and the guidelines are telling us, and what are reservations regarding the role of imaging, especially CT in the COVID-19 diagnosis. And at the end, there will be conclusion. So first question, where the Pakistan is standing. These are the stats released by Government of Pakistan today on 19th of April. If you look carefully, you can see total confirmed cases till today, we have 7,000 plus. The deaths till today are more than 140. The most affected province currently is the Punjab with maximum number of the current patient, and the maximum deaths so far have occurred in the KPK. So where we are, if you see our everyday confirmed positive cases from March 23rd till today, you can see slowly, gradually, our graph pattern is showing it's going up. So we are not down. And we are continuously having increased prevalence of disease with the time, with every day in our community. Considering still the fact that we are having complete lockdown, we are having continuous increase in number. Look at the total death versus total recoveries in Pakistan till today, 18th of April. Fortunately, if we compare this graph of us with the rest of the world, we are fortunate to have more recoveries than the death. But imagine the situation, God forbid, if there is no lockdown and we will end or enter in the second stage of this pandemic. The second question comes, why we need protocol and guidelines. To understand this question, we need to see where the world, what's happening around us, what's happening in the world. These are the stats. The USA and the Europe countries are badly affected by this pandemic. And consider also this fact that they are highly developed countries, highly developed regions of the world, which have best health facilities in their environment, even though they are still not able to win this war against the COVID-19. If you talk any person in Europe or America, any healthcare staff in Europe and America, they will define this situation as a situation of war. They are considering themselves in the state of war, considering so many deaths are here. So yes, we need the proper guideline so that we won't come in the top of the list in this, especially in this list, near these countries. So what are the current NIH recommendation and challenges we have? NIH is a National Institute of Health Services Pakistan. So this is the summary algorithm of COVID management pathway released by the Government of Pakistan. If you look carefully in this summary, you see the only diagnostic tool, I must say only diagnostic weapon for this war we have is the PCR. There is no other alternative. So if we have only this diagnostic weapon, so what are the limitations of our battle tool? The most important limitation of battle tool is its availability and shortage. Consider we are the country of population around 212.2 million. And what is our capacity of doing PCR in a day? This is the information. In a day, the government capacity at national level, including all the province, is not more than between 5,000 to 8,000 tests. So the most big challenge is the availability and shortage of this gold standard or a diagnostic rule. The other limitations are the results turnaround time. In my hospital where I am working, the turnaround time is between 8 to 24 hours. But in some other areas, it is up to 48 hours. And the other limitation is, again, the sensitivity, which is the biggest issue. The sensitivity of our our gold standard is varying between 42% to 71%. So imagine you have a single diagnostic tool which is not even having the sensitivity of around 100%. And there are the cases, around 29% of the cases when there's a possibility you will get the false negative results. Because probably these cases are having a false negative, they're coming false negative because they are in the early stage of the disease. This is a very important document. It's an excellent critique and review done by one of our radiology colleague, Dr. Aman Nawaz Khan from RMI Hospital, Peshawar, on the behalf of our Radiology Society of Pakistan. In this document, he beautifully identified the gaps present in the provided management pathway of the government of Pakistan currently. And on the basis of this, these gaps, he identified the challenge that Pakistan is going to have. So I will not go into the detail of this document, but what is the conclusion and gist of this document? What are the challenges for Pakistan currently based on the experience from China, Europe, and USA? According to him, we are in the stage 1 of the pandemic. If the trajectory of the cases shoot up like it did in US and Europe, we will face severe constraint of resources. When we say the resource constraint environment, that means we are already a country, a developing country who has the resource constraint environment. That means we have a limited capacity of testing. We have limited PPE equipment with us. We have limited COVID hospital, the quarantine facility, the ventilator, and the treatment facility. So we are already a resource constrained environment country. The other challenge is how you are allocating these patients into a specific cohort. How quickly you are doing it. Are you sending them to the hospital? Is there any way of sending them quickly to the quarantine or center of isolation? There is currently no mechanism of screening patients, especially those who have no COVID signs and symptoms, and coming to the hospital with other acute emergency. How you are going to screen them? And is there any way that you can exclude your triage process? And these are the challenging our country is facing currently with a population of 200 billion plus. So what is the answer? The answer is to have a good strategy. What should be our strategy? We need to strengthen our diagnostic tool in triage pathway to accelerate the process. What should we do? We should have a pre-planned diagnostic pathway, which include imaging in the hospital in addition to the right PCR to work with efficiency, not only for the treatment, but for the diagnosis, screening, disease stratification, and monitoring of the treatment response. What is the Chinese data saying? Why I'm quoting the Chinese data? Because this is the first country which was badly hit by this pandemic, and they are almost won this war against this COVID virus. So we really need to listen what they are saying, what they are recommending. According to them, in their many studies, they have found the initial sensitivity of CT scanner is around 96% or around the initial PCR sensitivity. But some of the studies have shown that this sensitivity is even more, the initial CT sensitivity is better than initial PCR sensitivity. The multiple data they have presented, which is showing the initial CT sensitivity for picking the COVID finding, diagnosing them, trial them, screening them is better than the initial PCR sensitivity. Western data. As you know, recently the Western world is badly hit after the China is badly hit by this pandemic. But when you review the Western data, there is lots of uncertainty about the guidelines, the recommendation. The example is, you see, these are the main bodies from the Europe and America. If you see the first statement regarding the role of imaging, especially the city, came from the British Society of Thoracic Imaging on 6th of March 2020. And at that time, they did not felt that there is a role of CT in the diagnosis of COVID. But again, they changed their statement a little bit. On the 11th of March, you can see here, And again, they were not convinced, they were not recommending, but they showed some flexibility and saying CT cannot be recommended in the screening, but may be used for the risk stratification where cases increases. How about the Royal College? What the Royal College of Radiology was saying? Their first statement came on 12th of March saying there is no role of CT in diagnostic workup. But on 27th of March, another statement came from the same college and saying the use of additional CT can be considered in the patient who are coming for the emergency procedures in the emergency room to quickly screen them with RT-PCR. ACR till 22nd of March 2020 was not sure and was not convinced about the role of CT in the diagnostic workup of these patients. But things started changing after the first week of April. On the first week of April, a statement came on 2nd of April 2020 from the European Society of Radiology and Thoracic Imaging saying, not for screening, but CT can be helpful for the patient with mild symptoms who have other comorbid or risk factors. I think this uncertainty is likely because of the dynamic changing the shape of this pandemic. So every day they are not certain, they are not able to come to the conclusion. Okay, during this time, in the last month, when the whole world was looking after the China towards the Western world to give them the guideline, the recommendation, what was happening in the Pakistan? The Radiology Society of Pakistan released its first version on 18th of March for our local practice for the COVID, and they strongly recommended the role of CT scan in the diagnostic workup of COVID, especially in the triage. Again, on 27th of March, Radiology Society of Pakistan again released the second version, again reinforcing, again emphasizing the role of CT scan during the triage of these patients, because they recommended that because there's a high chance the early RT-PCR in subclinical patient, especially in patient with mild symptoms, can come negative. This is what the recommendation till 27th of March. I will not go into the detail, just to make you a little bit aware of that. This is available on their site. If the patient is asymptomatic, you really don't need to do any imaging, just check with the PCR. But if the patient is having mild respiratory symptoms or having the comorbid, check with CBC and also done the CT. Or if the CT is not available, at least do the chest X-ray. And the patient who have the moderate or severe disease, while you're waiting for the RT-PCR, you need to quickly diagnose and triage these patients and stratify these patients. You need to take the help of CT imaging, do the CT and do the stratification of these patients. All this uncertainty about the Western world has become stopped after the 7th of April, when the Fleshner Society gave its consensus statement regarding the role of imaging in the COVID-19. Why I'm saying that this document is very important, because this is not a document or statement which came from a single society or a single country. It's a multinational, multi-consensus statement came from the Fleshner Society. So what they were saying, yes, they were saying imaging is not indicated in patients who were having the mild clinical feature, exactly what we recommended. Imaging is indicated in the patient who are showing the worsening of the respiratory symptoms and are having the other risk factors. And the most important statement which we need to understand, they said a resource-constrained environment, imaging is indicated for medical triage of patient with suspected COVID. I think this statement is more related to our scenario, to our country, where we have the resource-constrained environment, and those patients who are having the moderate to severe clinical feature with high pretest probability of the disease. Immediately after the 7th, on 8th of April, the Radiology Society of Pakistan completely endorsed this statement. So in their statement, they have given the 3 scenarios, but because of the shortage of time, I will only discuss the 3rd scenario. If you want to review the rest 2, you can go to their site, it's there, and you can easily read it and evaluate it. But the 3rd one, in my opinion, was most relevant and most critical to our environment, to the Pakistan. So in the 3rd scenario, they said, if a patient is having moderate to severe respiratory feature, having the high pretest probability. That means there's a high chance or there's a high prevalence of the disease in your environment, in your country where you're working or setting, or high contact history with the COVID patient is there, or you have a resource constrained environment. That means you need to urgently triage this patient, you have the lack of resources, you have limited bed, ventilators, medical equipment. Then with the rapid quick COVID testing, which is the PCR, you send it, but don't wait for the result. Either it's a positive or negative. You really need the imaging to be done to quickly triage these patients, to quickly stratify these patients and decide about their further fate. So when they are recommending the imaging, so we are confused. Either we should go for the CT or the X-ray. As we know, the chest X-ray has very poor diagnostic accuracy for the mnemonic parenchymal changes as compared to the CT. But again, the choice of the modality, especially, is totally depending upon your environment that you're working, the limitation of the environment, and the condition of the patient. If the CT is available, you can go for it easily. The ideal modality should be CT. But if you have the resource constrained environment, you don't have the facility of CT, at least do the chest X-ray. Or if your patient is sick enough or they're intubated, you cannot ask them to come to the radiology department. Yes, you can go for the X-ray, and especially in follow-up cases. This is the example of a patient who came with a suspicion of COVID. Initially, chest X-ray did not show any abnormality. CT chest done, and again, the patient who was not showing any abnormality on the X-ray showed the opacity. So this is how we are emphasizing over the role of CT in early triage and early diagnosing of this patient. So what about the patient? The very important question, who are not suspected, but living in an area where there's a high prevalence of COVID and coming to with other medical emergencies to you. This is a very important statement released by the Royal College of Edinburgh on 27th of March. And they said, acute patients are a priority. Any patient undergoing for abdominal CT scan, for any abdominal emergency, any situation which needs immediate surgical intervention, this patient should not only have the RT-PCR done, because there is a high possibility, because they are subclinical patient, the PCR may come false negative. So they need another diagnostic additional tool to confirm and to be sure that was the CT chest to pick the early changes, which can be easily missed on the RT-PCR. And this document or this statement is also followed by the College of Cardiologists. They're also going for the same pattern. If they are suspecting they need any intervention, they ask for the CT chest with RT-PCR. This is the imaging pathway for the patient who are coming with other emergency. If you need to do the surgical intervention, do the RT-PCR, but also do the CT chest to identify the subclinical patient. So what are the reservations regarding the role of COVID-19? As we said, when you have a problem, you need to see the pros and cons. Yes, the reservations are increased radiation of the population. Are we unnecessarily exposing them? Are we transmitting the COVID-19 to other patients who are coming to us for the diagnosis? Consumption of the PPE, contamination of the pathways, contamination of the department, and the cross-infection and the safety issue of our staff. So when there is a problem, there is always a solution for that. As I will not go into detail because Dr. Shazlee has talked about it very in detail. So yes, there are the guidelines which are available on CDC site, and they are on our website as well, which can help us, which can guide us to how we can prevent this transmission of infection from our department, and how can we avoid to be the vector of the infection spread. At the conclusion, I'm not saying the PCR is not a gold standard. It is the gold standard, but considering our resource-constrained environment, we need to strengthen our diagnostic tool, currently by adding the imaging in the triage pathway, as it is recommended by Fleschner Society as well. A resource-constrained environment like Pakistan, imaging is indicated for medical triage of the patient with suspected COVID who present with moderate to severe disease with high pretest probability of the disease. Last but not least, due to the whatever recommendations so far I have discussed with you, they are subjects to change because every day we are having the new information, the new literature is coming. So there might be some changes expected in these guidelines in future. If you have any query, any confusion, you want to have guidelines about the fight against this COVID, you can go to the Radiology Society website. There are multiple tabs are there which can help you in detail. And the last but not the least, we, the Radiology Society of Pakistan, humbly request you to kindly help us by contributing towards the cause of providing free masks, gloves, and gowns. Thank you so much.
Thank you very much, Dr. Kiran. It was really a comprehensive talk on the role of imaging and the guidelines, and you nicely comprehended all the different guidelines available. Now we'll move on to
Thank you
the
so much.
last speaker, Dr. Nadeem Ahmed, Chairman Department of Radiology, Arkham Hospital, the manufacturer of COVID, and he will share the different spectrum of imaging findings that we can see on imaging in COVID patient. Over to you, Dr. Nadeem.
Thank you very much, Azim. Two very nice talks by Kashif, Dr. Kashif and Dr. Kiran, and they set up this background. My job is to basically, in a very simple way, explain what we expect to see in the imaging in radiology, and I will go through them because my understanding is that a large number of participants today in this webinar are not radiologists. In fact, they are physicians for very wide background, and I'll try to keep this relatively simple. Can you all see my screen? A single screen there?
Yes, we can.
We can see that. We can see that.
Thank you. So this is my disclosure. I have no financial disclosure. Of course, just to show the complete spectrum of the imaging, I have taken a lot of published material as well as open source material with a fair disclaimer. So let's start with the chest X-ray. Chest X-ray is the most basic, easily available radiological modality. It is relatively less sensitive than a CT scan, but still it is an important tool. Whenever we are working in hospital, then and we have a separate area for COVID patient, then chest X-ray should be done in the wards, in the COVID areas by a portable unit. And many times in very early disease, chest X-ray may look normal, and in follow-ups it shows abnormality. So this is an example of early stage typical chest abnormality. If you notice, you will find out that in the periphery, closer to the bases, there are increasing opacities, and on both the sides. So a pattern is there. That means the disease, the shadows, the infiltrates are more peripheral. They are closer to the bases, and they are bilateral. This is another patient, and in this patient, if you notice, you will find out again the same kind of a pattern is visible, where you can see that infiltrates are present in bilateral areas closer to the bases and closer to the chest walls. So these are the typical findings, but in chest X-ray, you may find out a lot of areas where there is kind of a relatively indeterminate, it is not very clear. So this is an example where you will find out that the very fluffy infiltrates, they are not having a clear-cut pattern, and this requires further workup and confirmation through other tools also. This is another patient in which we find out basically lymphadenopathy, hilar areas, and this appearance is not very typical or very characteristic of the COVID. So what we see really in COVID patients, we see in COVID patients a pattern, and this pattern is basically we see peripheral consolidations. They are multifocal, they are closer to the bases, and that is what we see in that. We do not see a lot of infiltrates in early settings closer to the hilum. So we can, based on the basic patterns, classify the chest as very typical of COVID and high suspicion, or intermediate, indeterminate, or atypical, or completely negative. Atypical are those findings which are not. So I am showing a pattern here where the X-ray chest can be very typical or cannot be very typical for the abnormality. So we are now showing, seeing some of the examples which are about the severity, how much lung is involved, and the number of articles which are coming up, which are bringing in lot of approaches, how to measure, how to score in CTs, in X-ray chest. And here I'm showing one article which has recommended a very simpler approach here. And in this, there is no involvement, 25% score 1, 25 to 50% score 2, 25 to 50 to 75 score 3, and more than 75 score 4. And then it is on the right side or on the left side, and then status is to be maintained how many days for which the symptoms were present. And here you can see a very low score, an increasingly more score. Here the score is 3, and here the score is about 4, and here the score is about 7. These are the examples of the cases which are relatively mildly effective, very subtle infiltrates, you can see, and not very advanced stages. These are the example of X-ray chest which are moderately involved, about 50% on both the sides. And these are, again, if you notice that it is on the periphery, bilateral, and more towards the basis. And these are the example of very severe involvement of the chest. They are like almost white lungs. Sometimes they are mimicker of the ARDS like pictures. And these are usually very sick patients. You can see the chest tubes and other things. Sorry, the endotracheal tubes, and these are the indications that these are admitted in ICUs and those kind of settings. So what happens that on an X-ray chest? These are some of the examples where the findings or infiltrates, they are kind of less prominent, very subtle in the beginning, but with the progression of the disease, they were increasing in severity, they were increasing in involving larger areas of the lungs, and then the whole of the lungs. And then they may go into the deterioration. That means they go into the white lung situation, or they may improve. Most of the patient, alhamdulillah, they get improved over time, and we see resolution. This is the example in which there is quite a deterioration of the condition, and you can actually see how the lungs are getting badly affected, and they are completely involved, and they are white lung in severe sick patients. Now the chest X-ray versus CT. Dr. Kiran in her talk showed one case that there is an X-ray chest, which is early chest, which appears to be normal, but when CT scan was done, it showed infiltrates. So this is another example. The chest X-ray looks normal, but if you see, there were very early infiltrates, very early shadowing, or we call it ground glass opacity, that start appearing into the CT scan. So CT has got more sensitivity, much more sensitivity than an X-ray chest. So what are the most important findings which we look in a COVID patient in CT scan chest? Most important, we see ground glass opacities, and I will show you a few examples. Those ground glass opacities involved multiple lobes very commonly, and I'm showing all this from a reference which is below. These numbers are from that. Most of these opacities are subpleural or peripheral. That means closer to the chest wall. They are very less likely to be mediastinal or central. Eventually, they convert into the consolidations. And then we start seeing effects of fibrosis or septal thickening, interlobular septal thickenings. And then those lead to phenomena of bronchial wall dilatation, bronchial wall thickening, as well as vascular dilatations into those areas. So here are some of the examples of ground glass opacities. You notice that these are two different patients, and you can see that these are multifocal, they are peripheral, and they are bilateral. And the central areas are less involved. And this is very classical of those COVID involvement. These are another two examples. They're very early, very subtle changes are appearing. And these are the patients who may be asymptomatic or who may be in very early disease settings. And there is quite a large number of patients who may not have a PCR test positive, either because of its sensitivity issue or because of sampling errors issues, because sometimes the sampling error itself leads to less number of positivities. And these are the patients, if we see a negative PCR, we must recommend to have a repeat PCR testing, because at the end of the day, we label a patient COVID positive based on PCR, not based on X-ray chest or CT scan. But these are very, very helpful modalities. Now, these two different patients, they show again the concept of multiple lobe involvement. You can see that the upper lobe, the lower lobe, and the median lobe, all, and they're bilateral and they are peripheral. This is just remember, this is the commonest. And then these are subpleural in distribution. Eventually, these ground glass opacities becomes more organized. They become more, we call it consolidation, looks like pneumonia. They may have air bronchogram, and they increase in number and density. Sometimes they show a phenomena called reverse halo, in which there is a central lucency. Reverse halo is not specific for COVID, but this phenomena is seen in COVID patients also. The central lucency is surrounded by increased density called reverse halo sign. As the disease progresses more and more, we start seeing these septal thickness, interlobular septa, they become more and more prominent. You can see all these red arrowheads showing those thickenings. And we start seeing a kind of a, just a, a maze-like appearance, which is called crazy paving. This is called crazy paving. Crazy paving again is a pattern which we commonly see in CT chest, in HRCTs, but it is also seen in many other conditions, but also in the COVID patients. These are thickened interlobular or intralobular lines combined with the ground glass opacification. You can see another patient with high resolution, these crazy paving phenomena in this CT chest. As we see more and more abnormalities, we pick up that there are bronchial wall dilatation, bronchial wall thickening, along with the fibrosis and crazy paving things. And then we also see in these phenomena that the vessels becomes dilated. You know that there are a lot of debate going on about what is the actual pathophysiology. And I'm not going into that detail at the moment because of the time and because I want to keep this very simple. But vascular involvement is a very important area in the pathophysiological discussion of the COVID. And in this patient, you can actually see bronchiectasis, a little bit of bronchial dilatation, as well as vascular dilatation, ground glass opacifications, and a little bit of septal thickenings. And when the disease further progresses and it start resolving and patient starts improving eventually, then we start seeing this phenomena of subpleural bands and kind of a fibrotic and architectural distortion. These are again subpleural in location, and these are not very deep. They are more closer to the chest walls. There is another important phenomena, especially when the patients are sick, they are in the high critical care areas or they are in ICUs and they become deteriorated, then basically they start having a lot of pulmonary embolism. These pulmonary embolisms are not into the major vessels. These are basically into the very small vessels here, there, and those are another area. And in those cases, then we have to do a CT scan with a standard protocol with contrast and angiography, and sometimes we have to do subtraction also. So what are the highlights? The main CT feature of COVID-19 pneumonia is the presence of ground glass opacities. Ground glass opacities are the starting things. They are multifocal, they are peripheral, they are subpleural, they are bilateral, they are in many, many lobes eventually, but they may start at one single area eventually. So in very early cases, you may see just one, very subtle, or maybe two, and then from there it progresses. But these are the indicator in the right clinical setting, they should go through a PCR testing. So these are the things which are more common ones. And then the disease can be very mild, and this can be very, very severe. There are a lot of scoring methodologies which are coming up into the literature. According to this particular published article, this is about 10%, this is about 75% involvement of the lung. And you can see that severity. And these are the helpful signs and categorization which help us in stratification. So again, these are the articles which show what are the common ones: ground glass opacification, reticular and interlobular septal thickening, consolidation, and air bronchogram. They are bilateral, they are multi-lobes, they are present to the bases, they are more towards posterior and peripheral areas. But what are the things which we do not expect normally in COVID? We do not normally expect a lot of pleural effusion. We do not expect lymphadenopathy. We do not expect mass or nodules or specific zonal predominance or segmental or zonal involvement only, which we see in classical pneumonias. If we see these things, then the chances are that it is less likely to be COVID, and the other differentials should be considered. Then what happens in CT scan according to the time? Lot of articles are coming, and they are giving a different classification. Broadly 4 stages: early or initial stage in 0 to 4 days, in which there is normally a ground glass opacities. Then we call it progressive stage or advanced stage. As symptom increases, 5th to 8 days, increased ground glass opacities and crazy paving appearances. Then we see severe consolidation stage. Some people call it peak stage. And this is in 9 to 13 days. And then from 15 days or 14 days onward, if the patient improves and start healing, then we see dissipation stage or absorption stage, where we see the subpleural bands of fibrous stripes. Quickly going through those examples, and this I am taken from the publication published on the pages of Radiology Society of Pakistan. Thanks for that, but these are mostly published material. These are very, very early ground glass opacifications. In early stages, they start increasing, they start coalescing, they involve many, many more lobes, their numbers and densities are increasing. And then in the rapid progressive stage, they become showing crazy paving, fibrotic interlobular septal thickenings. And further, they go into classical consolidation. They are multifocal, patchy consolidations. And when they go into the dissipation, then they start resolving, the density becomes decreasing, and we start seeing these subpleural bands phenomena appearing into the lungs. And when they become healed, gradually the lungs becomes clearer, and these are the examples of that. So what are the differences in children? We know that COVID is more serious in elderly population, but it is also involving almost every age group. And we know that children are also, and many of you who are listening this may be dealing with child population in your clinics or in your practices. So they are not much different, but generally they have low incidences, slighter clinical symptoms, shorter course of disease, and fewer severe cases. The overall situation is better. The chest characteristic of COVID-19 in pediatric patients were atypical, with more localized GGO extent. GGO is ground glass opacification, lower ground glass attenuation, and a relatively rare interlobular septal thickening. That means they were just soft shadows. They didn't go into advanced stages commonly, and they healed generally. So this is what we see in the children population. But then the appearances of the CT scan is not classical of COVID all the time. We must keep in mind that there could be many, many other diseases which could mimic, and therefore we continue to put into practice the other screening phenomena, the right clinical settings, as well as the use of PCR testing. And there are a lot of differential diagnoses also. But because this is a time of pandemic, we should keep our suspicion of index very, very high, and therefore start diagnosing. So if you see this, this is a mimicker, which is a SARS, which looks like a COVID patient. And here also some of the patterns like centrilobular or nodular involvement and segmental involvement are not typical of COVID, and these are the differential for the infections. And similarly, the COVID can happen with other complications. In this patient, there was myocarditis or cardiac failure, and there are changes of pulmonary edema along with COVID changes. So the COVID patients eventually may have complications, may have other things, and we have to see that with that background and understanding also. So important consideration is that the CT finding of COVID may overlap with other diseases, and these are the common ones: H1, influenza, CMV, adeno, organizing pneumonia, and acute interstitial pneumonia. So by no means we are saying that CT scan is most diagnostic, most specific. There could be differential diagnosis, but it is a very helpful tool in the right clinical settings with the more common and typical chart. And these are the two quick examples of references. This is from the RSN expert panel. CT findings can be classified like I have shown you, that X-ray chest could be typical findings, intermediate, atypical, or negative. And based on that, typical, indeterminate, atypical, or negative, we can classify our CT scan. Similarly, the British Society of Thoracic Imaging has come up with their own criteria or methodology of classic, probable, indeterminate, or non-COVID. This is almost the same with slight variation, but generally they are saying the same thing, which I have been explaining you into the last 10-15 minutes. And this is a scheme. These are the ones which are the more common ones. If we see these changes: ground glass, bilateral, multilobular involvement, peripheral distribution, opacities which are rounded, linear, subpleural, crazy paving, then it is a very highly suggestive. And these are the ones which are less likely. If we see these things like tree and bird, central positions, lymphadenopathy, pleural effusion, then they are less likely. Sometimes they are mixed, and it is called indeterminate. A quick word about the technique. Generally, these are done with HRCT technique, but there are a lot of publications which are coming up which recommend that we can apply a low dose CT scan can show abnormalities, may not show the details in great detail, but help us in differentiating and triaging the patient. Few quick slides about ultrasound. Ultrasound, there are few papers which are coming about the ultrasound, but ultrasound is some people do it, some people don't do it. It is heavily dependent on the expertise, availability, as well as quite a risk of exposure to the performer. So it is not picking up in many settings because of the risk. But quickly, the linear probe and convex probe can show different patterns. If they are horizontal lines, which are called A lines, then it is a normal pattern. This is a normal pleura. If this pleural line is thickened, irregular, and the larger number of white lines which are vertical and they are wider and intermixed by the black areas, then the more severe this pattern is, the more heavily involved the lung is because of underlying consolidations as well as fibrosis. These are called B line and A line and B lines, and these are the this particular area shows the comparison of the very abnormal and a very normal looking chest. And this image, I got it from a social media. I couldn't find out its reference, but it is an extremely nice and very well depicted image. This is a normal appearance. The higher the number of lines, the thicker they are, and they're more irregular, they are the advanced disease. And a lot of people are suggesting, and in this article there's a suggestion of how we can triage. For example, in this particular control at home, when the B line are multiple, that means it is require hospitalization and oxygen. And if they are frank consolidation, then it means critical care admissions. And thank you very much with that. I'm sorry, probably few minutes have been passed over. I end up here. Thank you.
Thank you very much, Dr. Nadeem. It was a wonderful presentation and wonderful overview of the radiological findings in chest X-ray, CT scan, and ultrasound in COVID patient. So, first of all, we have already crossed over the limit, the allocated time. It's 12 past 5. But I'm thankful to the organizer, and they are willing to extend the session for another 15 minutes. So I have received first of all, I would like to once again thank the organizer, Gets Pharma, as well as the Health Asia. Both of them have collaborated in bringing up this session. I'm thankful to Health Asia as well. So I have received many questions, a lot of questions. I don't think we will be able to answer all those, and some of the questions are beyond the scope of this presentation, but I'll share with you. So, first question is from Dr. Kashif. Kashif, do you think we should do antenatal ultrasound at this point in time? What should be the protocol?
ओके एंड अगर कोई उसकी कोई इमरजेंसी नहीं है तो एंटीनेटल अल्ट्रासाउंड शुड बी पोस्टपोन्ड। अगर कोई ऑलरेडी डिजीज था, कोई पहले से कोई कंजेनाइटल डेवलपमेंटल एबनॉर्मेलिटी सस्पेक्टेड, देन वी can scan with all precautions, but I think it is wise to postpone all the elective procedures, including antenatal ultrasound visits.
Okay. There are a couple of questions which I'll take up simultaneously, and Dr. Kashif is requested to answer those questions. And I'll read three questions. They are almost similar, but a bit. Number one is how to sterilize the tools, which I think you have already told us. And number two, what is the protocol of cleaning the room after we take a COVID positive patient in a radiology room? And number three, how can we prevent if a patient is expectorating or coughing, COVID positive patient inside the room, how to minimize the transfer of virus by its airborne droplet infection?
अच्छा, इसमें सबसे पहले इम्पोर्टेंट ये है कि तमाम डिपार्टमेंट्स अपना अपना SOP बना लें। जितने भी रेडियोलॉजी में, अगर ये रेडियोलॉजी से सिर्फ फोकस्ड ऑन द रेडियोलॉजी है तो every radiology department should develop its own protocol according to their situation and ground realities. उसमें दो तीन चीज़ें बहुत इम्पॉर्टेंट है। नंबर वन, ये पेशेंट स्केड्यूल्ड होना चाहिए, ये इमरजेंसी से डायरेक्ट नहीं लैंड करना चाहिए। द कोविड पेशेंट मस्ट बी स्केड्यूल्ड एटलीस्ट हाफ आवर बिफोर radiology reception should receive the call for this patient. Number one. Number two, the corridor जो जहाँ से आना है उसको the track of the patient और जो लेके आ रहा है स्टाफ वो आइडेंटिफाई होना चाहिए। नंबर थ्री, जब इस इमेजिंग कर रहे हों तो जो अंदर उस प्रीमिसेस के अंदर 2 से ज़्यादा लोग अलाउ नहीं है, यानी एक अटेंडेंट जो उसके साथ आया है, चाहे वो स्टाफ हो चाहे अटेंडेंट हो, दूसरा आप या आपके साथ एक कोई वर्कर, तो 2 लोग से ज़्यादा ना हो, कोशिश करें 3 से मैक्सिमम तो बिल्कुल ना हो। नंबर 4, स्कैन टाइम शुड बी वेरी मिनिमाइज्ड, फ़ौरन से करें और जिस वक्त पेशेंट स्केड्यूल होगा उसी वक्त आपने रेडियोलॉजिस्ट को ऑन बोर्ड लेना है। वो कहीं और बैठा हुआ है तो वहीं पे बैठ के इमेजेस को ओके करेगा और उसके बाद आप फ़ौरन पेशेंट को आपने वहाँ से भेजना है। नंबर 5, आपने जैसे ही पेशेंट जाएगा तो आपकी इन्फेक्शियस डिजीज़ कंट्रोल अगर मौजूद है तो उसको अलर्ट कर दें, वो आएंगे, वो अल्कोहल स्वैब से तमाम सरफेसेस को करेंगे, जिस टेबल के ऊपर पेशेंट है उसको या जहाँ टच हुआ है पेशेंट या उसके साथ जो अटेंडेंट थे, तो तमाम सरफेसेस अल्कोहल स्वैब से होंगी। जो फ्लोर है वो ब्लीच से होगा, वो ब्लीच से मॉप लगाना है उसका, ठीक है। और अगर उसमें फ्यूमिगेशन की ज़रूरत है तो ट्रैक की होगी, जिस कॉरिडोर से आ रहा है फ्यूमिगेशन उस कॉरिडोर की होगी, सिटी स्कैनर वाले रूम की नहीं होगी। दिस इज़ नॉट रिकमेंडेड। और बाकी सर्जिकल मास्क और सारी चीज़ें आपने लेनी है, जो PPE पहनना है वो पूरा प्रोटोकॉल में बता चुका हूँ कि किस स्टाफ ने किस वक्त कौन सी चीज़ पहननी है।
ठीक है डॉक्टर काशिफ, एक और इंटरेस्टिंग क्वेश्चन है, सवाल है कि डज ओवर एक्सपोजर विद रेडिएशंस लोअर द स्ट्रेंथ ऑफ PPEs?
मुझे पता नहीं है इस बारे में, मैंने कभी पढ़ा नहीं है, लेकिन जो रेडिएशंस होती हैं वो तो क्रॉस कर जाती हैं जो स्टफ़ हम पहनते हैं कपड़े वगैरह, उन स्टफ़ के बारे में मैंने कभी ज़िंदगी में किसी लिटरेचर में पढ़ा नहीं कि इवन ये जो मैंने अभी टी-शर्ट पहनी हुई है कि ये वीक हो जाती है और रेडिएशन से, रेडिएशन तो क्रॉस कर जाती है। तो मेरा ऐसा ख्याल नहीं है, लेकिन मैं लिटरेचर में सर्च ज़रूर करूँगा इसको। इंटरेस्टिंग क्वेश्चन।
एक और सवाल है आप ही से कि व्हाट इज द रोल ऑफ पोर्टेबल सर्विसेज एंड शुड दीज सर्विसेज बी टेकिंग टू द होम लेवल? अगर किसी को एक्सरे की जरूरत हो तो क्या घर पर करवाए पोर्टेबल बुलवा कर?
कोविड का पेशेंट
नहीं, किसी भी पेशेंट की बात हो रही है ये कि
अगर नॉन कोविड की तो सर्विसेज पूरे हमेशा हमने देखी है कि होती हैं, लोग घर जाते हैं, ऐसे पेशेंट्स होते हैं जिनको ट्रांसफ़र नहीं किया जा सकता। इस वक्त तो अगर इलेक्टिव है तो कोई भी प्रोसीजर रिकमेंडेड नहीं है, लेकिन अगर पोर्टेबल जो हम रिकमेंड करते हैं वो पोर्टेबल डिवाइसेस को कि जब कोविड वार्ड है या ICU है वहाँ की मशीन्स डेडिकेटेड कोविड वार्ड में ही रहनी चाहिए। एक्सरे मशीन, अल्ट्रासाउंड मशीन बिल्कुल बाहर नहीं निकलेगी वहां से। एक मरतबा अंदर जाएगी, जब ये इंशाल्लाह खत्म होगा कोविड एरा, तो फिर ही बाहर आएगी। अनटिल अनलेस के बायोमेडिकल किसी इसको ठीक करने के लिए ला रहे हो, तो उससे पहले भी आपको पूरा प्रोटोकॉल लेना पड़ेगा, आईडी को इन्वॉल्व करना पड़ेगा, इन्फेक्शियस डिजीज कंट्रोल डिपार्टमेंट को, वो उसको साफ करके बाहर निकालेगी। तो ये चीजें रखनी है। वैसे इस वक्त वाइस नहीं है, एडवाइजेबल नहीं है कि आप घर पे जाके एक्सरे और अल्ट्रासाउंड करते फिर।
डॉक्टर अजीम आप म्यूट है, डॉक्टर अजीम आप म्यूट है, दोबारा दोहरा दीजिए।
और आई एम सॉरी, यहाँ अजान हो रही थी इसलिए मैंने अपने आप को म्यूट कर दिया था। जी, मैं कह रहा हूँ कि इनिशियल क्वेश्चन डॉक्टर काशिफ की टॉक के बाद आए थे, तो तमाम उसी से रिलेटेड थे। अब और भी क्वेश्चन बहुत उसके बाद बहुत सारे आए हुए हैं। डॉक्टर नदीम, आपसे सवाल है कि इज देयर एनी रोल ऑफ MRI?
नॉर्मली नॉट, क्योंकि 90% जो इसका इफेक्ट है वो चेस्ट और लंग्स पे है, और उसके लिए बेस्ट टूल्स हमारे पास ये 3 ही हैं जो हमने आपको बताए, उसमें सबसे इफेक्टिव CT स्कैन है। लेकिन चूंकि ये डिजीज जैसे जैसे हमारी नॉलेज बढ़ रही है और ज़्यादा हमें पता चल रहा है, वैसे वैसे लिटरेचर चेंज भी हो रहा है, और हमको ये पता है कि डिजीज हार्ट को इफेक्ट कर रही है, ये डिजीज किडनीज को इफेक्ट कर रही है, एंड लिटरेचर में कुछ न्यूरो के रिलेटेड भी पेपर्स आ चुके हैं। तो अगर इस तरह की कॉम्प्लिकेशन कर रहा है तो उन सेटिंग्स में MRI का रोल बनेगा, पर नॉर्मली जो रन ऑफ द मिल कोविड है और रिलेटेड जो वर्कअप है उसमें MRI यूजुअली इस्तेमाल नहीं होगा।
एक सवाल ये कि व्हाट इज द सेंसिटिविटी स्पेसिफिसिटी ऑफ HRCT? कुछ इसमें है डेटा कुछ?
किरण ने कुछ, डॉक्टर किरण ने कुछ, जी डॉक्टर किरण ने कुछ हमें स्टडीज दिखाई थी। मोस्ट ऑफ द स्टडीज जो है वो कहती हैं कि सिम्टोमेटिक पेशेंट्स में जिनके अंदर सिम्टम्स आ गए हैं और उनको 3-4 दिन हो गए, तो उनमें सेंसिटिविटीज जो है वो 80 और 90% से ऊपर जाती हैं। कुछ पेपर्स तो 100% भी कहती हैं CT स्कैन की, और CT स्कैन में जो मोस्ट कॉमन प्रोटोकॉल है वो HRCT ही इस्तेमाल किया जाता है इसमें। जी
I totally agree. Yeah. Agreed with Dr. Nadeem. They are the Chinese data which have shown the sensitivity up to 100 to 96% against the gold standard, which is the PCR.
लेकिन इसमें ये ख्याल रहे कि जब पेशेंट को सिम्टम नहीं है, वो बहुत अर्ली स्टेज में, उसमें वो नेगेटिव हो सकता है। उस सूरत में पेशेंट को फॉलो करना होगा। हमें हिस्ट्री ऑफ कांटेक्ट, हिस्ट्री ऑफ सिम्टम्स और बाकी चीज़ों के पैरामीटर्स को देखना पड़ेगा, और अगर उसको सिम्टम डेवलप होते हैं, जब सिम्टम डेवलप हो जाते हैं, सेंसिटिविटी बहुत हाई हो जाती है।
मैं ऐड करूं एक चीज़, एक बहुत इंपॉर्टेंट है फॉर आवर सर्जन्स, हमारे जो एनेस्थीसिया के लोग हैं, कि जो नेगेटिव प्रिडिक्टिव वैल्यू ड्यूरिंग सिम्टोमेटिक पीरियड ऑफ कोविड इज ऑलमोस्ट 85%। यानी अगर कोविड सिम्टोमेटिक पेशेंट है और वो ER में लैंड करता है विद सम अदर इमरजेंसी, यानी उसका रोड ट्रैफिक एक्सीडेंट हो गया, या अगर कोई और उसको और कोई स्ट्रोक वगैरह सस्पेक्टेड है और उसको कोविड के सिम्टम्स भी थे 2-3 दिन से, तो नेगेटिव प्रेडिक्टिव वैल्यू ऑफ CT इज अप टू 83-85%। दैट इज वेरी इंपॉर्टेंट कि आप फिर इतना डिले नहीं करेंगे सर्जरी को, आप जस्ट CT कराएंगे। अगर वो नेगेटिव आता है तो हायर चांसेस हैं कि इसको कोविड नहीं है सिम्टोमेटिक पेशेंट्स के अंदर, तो आप सर्जरी वगैरह के लिए ले जा सकते हैं।
मैं इस क्वेश्चन को बहुत अच्छे से कंक्लूड करना चाहूंगी कि क्वेश्चन जो खास तौर पे हमारे कुलीग फिजिशियन से आता है कि अगर आप आपके पास एक ऐसा पेशेंट भी है, आप सिर्फ कोविड को ही डील नहीं कर सकते इस पैंडेमिक में, आपके पास बहुत सारे पेशेंट हैं जिनको एब्डोमिनल इमरजेंसी है, जो कहीं आपको कार्डियक इमरजेंसी के साथ आ सकते हैं, किसी भी न्यूरोलॉजिकल इमरजेंसीज के साथ आ सकते हैं, तो हाउ टू डील विद दिस पेशेंट, दिस इज द क्वेश्चन। Then if the answer is, if any of them required any intervention, चाहे वो किसी किस्म की न्यूरो इंटरवेंशन हो या कार्डियक इंटरवेंशन हो या एब्डोमिनल इंटरवेंशन हो, नो मैटर आपका पेशेंट क्लिनिकल सिम्टम्स और साइंस ऑफ कोविड नहीं रख रहा, लेकिन आपको ये कंसिडर करना पड़ेगा इस पैंडेमिक को कि आपका हर पेशेंट हैज टू कंसिडर एज अ कोविड पॉजिटिव until and unless proven otherwise with 2 diagnostic tool which include PCR and CT chest. These are the recommendations.
और इसमें सॉरी मैं आखिरी जुमला और बोल दूं डॉक्टर अजीम, वो ये है कि बहुत सारी जैसे डॉक्टर किरण ने हमें गाइडलाइंस दिखाई थी सर्जरी की सोसाइटीज़ की और न्यूरोलॉजी सोसाइटीज़ की और कार्डियक सोसाइटीज़ की आ गई हैं कि अगर हमें किसी पेशेंट को अर्जेंसी में हमें OR में लेके जाना है या प्रोसीजर रूम में लेके जाना है और हमारे पास इतना टाइम नहीं है बिकॉज ऑफ मेडिकल इमरजेंसी के RT-PCR का वेट करें, तो एटलीस्ट CT चेस्ट जरूर करा लें, ताकि हम गलती से भूले से कोई कोविड पॉजिटिव पेशेंट लाइक OR में ना ले जाएं। अगर वो ऐसा जाएगा और बाद में पता चलेगा तो पूरे अमले को, डॉक्टर को, स्टाफ, नर्सेस को और सबको क्वारंटीन में जाना पड़ेगा और वो कमरा आपको बंद करना पड़ेगा फॉर फुल डिसइंफेक्शन। तो इस वजह से इट्स रिकमेंडेशन जो कि अब आ रही है कि ऐसे पेशेंट्स से पहले सीटी स्कैन करा लिया जाए। जी डॉक्टर अजीम।
अच्छा जी, इसी सिलसिले से कंटिन्यूएशन का सवाल है कि एक तो सवाल ये है कि हम कब एक्सपेक्ट करते हैं सीटी चेस्ट पॉजिटिव आना, कितने दिन बाद कोविड इन्फेस्टेशन के? एक बात। दूसरे ये कि अगर वो नेगेटिव है तो कितने दिन में हम कोई भी रेडियोलॉजिकल इन्वेस्टिगेशन रिपीट करें? और तीसरा सवाल इसी से रिलेटेड है कि ये कोविड नेगेटिव हो जाता है पीसीआर, तो चेस्ट एक्सरे या सीटी चेस्ट की फाइंडिंग्स कब रिवर्ट होती है, नॉर्मलाइज कब होगी? 3 सवाल होंगे डॉक्टर नदीम।
जी किरण।
अच्छा, आप कहना चाहें? जी किरण बोल।
Okay.
गो अहेड।
Okay, I would like to take this question. सबसे पहले क्वेश्चन ये है कि जब पेशेंट आए तो आप पहली इमेजिंग कब करें, ठीक है, फर्स्ट इमेजिंग कब करें? तो आंसर इज इट डिपेंड्स अपॉन 3 फैक्टर्स। नंबर 1, आपके पेशेंट के सिम्टम्स कैसे हैं, द चांसेस जो आप हिस्ट्री में मालूम करते हैं एपिडेमियोलॉजी में कि चांसेस ऑफ, यानी कि प्री टेस्ट प्रोबेबिलिटी कि कितने चांसेस हैं कि आपके वो बंदा एक्सपोज हुआ है। एक दूसरी चीज आप ये देखते हैं। तीसरा आप ये देखते हैं कि आपके पास एनवायरनमेंट कैसा है, कि आप उसको क्वारंटीन कर सकते हैं, आपके पास मेडिकल फैसिलिटीज कैसी हैं। तो आंसर ये है कि अगर माइल्ड सिम्टम्स हैं और उसको कोई कोमोर्बिड है, आपको इमीडिएटली एक्सरे या सीटी करना है, जो भी आपके सहूलत में अवेलेबल है। और मॉडरेट और सीवियर है, आपको इमीडिएटली इमेजिंग करनी है, दोनों विद द आरटीपीसीआर। बट इफ पेशेंट इज ओनली हैविंग एक्सपोजर हिस्ट्री, उसको कोई सिम्टम्स नहीं है, देन यू डोंट नीड टू डू एनी इमेजिंग। कमिंग टू द नेक्स्ट क्वेश्चन जो आपने पूछा कि उसको हम कितने अरसे बाद रिपीट कराएंगे, ये पूरा डिपेंड करता है आपकी क्लिनिकल असेसमेंट में। अगर पेशेंट क्लिनिकली शोइंग रिस्पिरेटरी डिस्टोरिएशन, उसका खत्म रिस्पिरेटरी फेलियर में जा रहा है या खत्म हो रहा है, तो इट इज अ क्लिनिकल थिंग दिस यू नीड टू आंसर। ये उस पर डिपेंड करेगा और फिर उसमें ये डिसाइड करना कि वो पेशेंट का सिटी होगा या एक्सरे। अगेन ये आपके स्टेबिलिटी ऑफ द पेशेंट के ऊपर डिपेंड करता है। एंड आइडियली सिटी, लेकिन अगर आपका पेशेंट नहीं कर सकता, एटलीस्ट गेट द चेस्ट एक्सरे डन टू सी द प्रोग्रेशन ऑफ डिजीज। कमिंग टू द थर्ड क्वेश्चन कि आप फॉलोअप, अगर वो आरटीपीसीआर हो चुका है और आपका पेशेंट रिकवर क्लिनिकली कर चुका है, तो डू यू नीड दिस? तो आंसर मेरे ख्याल से ये क्वेश्चन यही है कि हमें कॉम्प्लिकेशंस देखने के लिए क्या करना होगा। तो टिल डेटा, आज की तारीख में वी डोंट हैव एनी डेटा अबाउट द कॉम्प्लिकेशन। वी डोंट नो हम अगले आने वाले महीनों में क्या कॉम्प्लिकेशन ऑफ दिस वायरस ऑन पल्मोनरी फंक्शन या लंग में हमें नजर आएंगी। तो फॉर दैट वी नीड टू वेट फॉर इट। बट अगर पेशेंट आपका एसिम्प्टोमेटिक है, यू डोंट, आपका आरटीपीसीआर या आपका पीसीआर नेगेटिव आ गया है, स्टेबल है, यू डोंट नीड टू रिपीट द इमेजिंग अनटिल अनलेस पेशेंट दोबारा डिटोरिएट होना शुरू होता है। तो यू लुक फॉर द कॉम्प्लिकेशन, लाइक जैसे डॉक्टर नदीम ने पल्मोनरी एम्बोलिज्म का जिक्र किया था, पेरिकार्डियल फ्यूजन का जिक्र किया था, देन यू लुक फॉर द एनी अदर सेकेंडरी प्रॉब्लम।
बस इसमें एक लाइन और ऐड ये करेंगे कि हर मरीज का जो कोर्स ऑफ डिजीज है वो डिफरेंट है। कुछ लोग बिल्कुल माइल्ड सिम्टम के बाद रिकवर कर जाते हैं, कुछ लोग फुल साइकिल लेते हैं, दे बिकम वेरी सीरियस, दे गो थ्रू आईसीयू एंड देन दे रिकवर। तो जो जितना सीवियर स्टेज में जाएगा उसकी रिकवरी इमेजिंग वाइज, उसकी इमेज क्लियरेंस उसकी उतनी ही देर से होगी और ज्यादा कुछ चांसेस हैं कि वो बहुत अरसे तक उसमें फाइब्रोटिक बैंड और स्ट्राइप्स रहेंगे उसमें। जी हाँ अजीम, आप फिर म्यूट पर हैं। अजीम आप म्यूट पर हैं। डॉक्टर अजीम।
Can we rely on X-ray findings as laboratory PCR and kits are not available everywhere in Pakistan?
Sir, can you repeat your question?
यानी क्या हम क्या chest X-ray को, okay, can we take chest X-ray alternate to PCR?
Should I answer? Okay.
नहीं है हम, हाँ किरण आप बताएं।
Okay, so what especially the Chinese data is saying, especially in a resource constrained environment, अगर आपके पास एक वक्त ऐसा आ जाए, कंसिडरिंग द चाइना की सिचुएशन में जब बहुत बैड पैंडेमिक आया था, they were at that time they were having a severe shortage of RT-PCR kits. So what they used, the other alternative diagnostic tool was the imaging. They use the imaging, especially the CT imaging. लेकिन अगर आपके पास वो भी नहीं है, आपके पास PCR भी नहीं है, आपके पास है कि पैंडेमिक के पेशेंट आ रहा है, सिम्टम्स है, और आपके पास हिस्ट्री भी दे रहा है कॉन्टैक्ट की, तो आप इमीडिएटली चेस्ट एक्सरे करें, एटलीस्ट अर्ली ट्राइज दैट पेशेंट के डिसाइड कर लें। जब तक कि उसका पीसीआर अरेंज नहीं होता तो एटलीस्ट आप उसको आइसोलेट कर दें और अकॉर्डिंग टू द सिम्टम्स को ट्रीट शुरू कर दें। जैसे मैंने कहा था, अनटिल एंड प्रूवन अदरवाइज आप उसको कोविड सस्पेक्ट करेंगे।
लेकिन इसमें वर्ड ऑफ कॉशन ये है कि इमेजिंग इज नॉट रिप्लेसमेंट ऑफ RT-PCR, क्योंकि गोल्ड स्टैंडर्ड वही है, लेबलिंग उसी की बेसिस पे होती है।
या अगर वो अवेलेबल नहीं है,
हाँ, अगर राइट क्लिनिकल सेटिंग में एक्सरे चेस्ट पॉजिटिव आता है तो इट इज वेरी सजेस्टिव, लेकिन अगर वो नेगेटिव आता है तो हम उसको एक्सक्लूड नहीं कर सकते डिजीज को।
हम सिर्फ प्रिकॉशनरी उसको अर्ली ट्राइज कर सकते हैं।
एक क्वेश्चन है कि इन गवर्नमेंट हॉस्पिटल देयर इज ह्यूज क्राउड ऑफ पेशेंट्स नॉट कोविड डायग्नोसिस, इज इट रैशनल टू कीप इट ओपन फॉर रनिंग और वॉक इन पेशेंट्स? मतलब क्या करें, डिपार्टमेंट की क्या पॉलिसी होना चाहिए? जी डॉक्टर नदीम।
नहीं, मैंने सवाल नहीं सुना, सॉरी, थोड़ा सा ड्रॉप हो गया था, आप दोहरा दें या कोई और जवाब?
सवाल ये है कि पब्लिक सर्विस हॉस्पिटल या जैसे भी हॉस्पिटल जिसमें बहुत ज़्यादा पेशेंट्स का इन्फ्लक्स है और वहाँ डायग्नोसिस पता नहीं है कि कोविड है, तो उन पेशेंट को रूटीन सर्विसेज वो डिपार्टमेंट दे?
नहीं, ये तो डॉक्टर काशिफ ने बहुत अच्छे से एक्सप्लेन किया है कि आपने डॉक्टर काशिफ ने बहुत अच्छे से एक्सप्लेन किया है कि जब तक हम इंश्योर नहीं कर लेते कि स्टाफ की और पेशेंट्स की सेफ्टी और सोशल डिस्टेंसिंग को हम नहीं उनकी सर्विसेज को हम होल्ड करके रखें। आइडियली जब पेंडेमिक का जोर है तो आपकी सर्विसेज सिर्फ इमरजेंसी और अर्जेंट केसेस के लिए रहनी चाहिए। कुछ चीजें होती हैं जिन्हें हम सेमी अर्जेंट कहते हैं, जैसे मोस्ट अर्जेंट है, फॉर एग्जांपल एक्यूट एब्डोमेन का पेशेंट है, उसको तो आपको देना है सर्विस। लेकिन फॉर एग्जांपल ऑन्कोलॉजी है, या किसी ने सवाल किया था एंटीनेटल का, बच्चों ने तो पैदा होना है, तो ये सेमी अर्जेंट है, जो एक दिन की या 2 दिन की अर्जेंसी तो नहीं है, लेकिन 2-3-4 हफ्तों में जाके वो अर्जेंट सिचुएशन कन्वर्ट हो जाती है। तो उनको भी आपने प्रॉपर तरीके से पीपीई के साथ, स्क्रीनिंग के साथ लाना है और खुद पूरी प्रिकॉशन लेके उनको सर्विसेज देनी है। लेकिन किसी भी सूरत में डिपार्टमेंट को या अस्पताल को इस तरीके से नहीं कन्वर्ट करें कि जहाँ क्राउड्स हो, अनकंट्रोल्ड हो। डॉक्टर काशिफ ने बड़े अच्छे से बताया था कि हर पेशेंट हर आदमी जो कि डिपार्टमेंट में या अस्पताल में दाखिल हो रहा है, उसकी सर्टन किसी किस्म की स्क्रीनिंग होनी चाहिए, हर स्टेप के ऊपर उसको चेक करना चाहिए, और जब भी आप उसको कोई सर्विस दें तो अपनी सोशल डिस्टेंसिंग और एप्रोप्रिएट पीपीई के हिसाब से दें। और अगर आपको किसी भी पॉइंट पे लगता है कि वो सस्पिशियस है तो उसको कोविड स्क्रीनिंग क्लिनिक्स में या रिलेटेड सर्विसेज को रेफर कर देना चाहिए। So answer is no, don't go for a full-fledged routine operation at this point in time.
ठीक है, शुक्रिया डॉक्टर नदीम। आखिरी सवाल जो है मैं खुद जवाब दूंगा। एक क्वेश्चन आया है कि इज देयर एनी रोल ऑफ इंटरवेंशन रेडियोलॉजी इन कोविड-19 पेशेंट? तो आंसर इज क्लियरली नो, इट हैज़ नो रोल इन डायग्नोसिस। अलबत्ता ये कि अगर किसी पेशेंट को जो कोविड-19 है और किसी रेडियो इंटरवेंशन प्रोसीजर की ज़रूरत पड़ गई तो दैट इज़ अ नाइटमेयर फॉर इंटरवेंशन रेडियोलॉजी, क्योंकि उसके प्रोटोकॉल स्ट्रिंजेंट है मोर देन सीटी। उसके पहले कैसे करेंगे, प्रिपेयर करेंगे, बाद में कैसे डिसइंफेक्ट करेंगे, यानी वन प्रोसीजर उसके आगे पीछे जो है इट मे टेक 20 मिनट्स प्रोसीजर मे रिजल्ट इन 3 or 4 hours ऑफ वर्क। तो डायग्नोसिस में तो कोई रोल नहीं है, और अगर पेशेंट को किसी को जरूरत पड़ती है तो इट इज़ रियली अ डिफिकल्ट डिसीजन टू हाउ टू प्रोसीड। तो अनलेस इट इज़ really life saving or it is very important that we have to do it, all these procedures should be postponed. So with that I think we can now conclude our session because it's already past 5:30. So once again I would like to thank all the speakers, Dr. Kashif, Shazlee, Dr. Hiral and Dr. Nadeem for their time and for their Gats Pharma, especially Mr. Hussain Arti, who was the main coordinating person with us and his IT team. I am also thankful to Asia, Web IT and all those who were involved in this session. Thank you very much. Allah Hafiz.
Thank you.
Stay
Thank you.
Stay at home.
Thank you.
Stay safe.
Thank you.